Ladies and gentlemen, dear doctors, thank you for joining our female reproductive health webinar. My name is Grace Estefan, and I'm here to welcome you all to our session entitled Modalities to Preserve Female Fertility, powered by Omnia Health. This webinar starts with valuable insights into the prevalence of infertility and the advancements in reproductive technologies presented by a renowned expert, namely Dr. Amr Ma'moon, a consultant of clinical genetics at Cairo University Medical School. Dr. Ma'moon holds a degree in clinical and molecular cytogenetics from the University of Montpellier in France. He is a renowned clinical geneticist with vast experience in breast, ovarian, and colon cancers. Following Dr. Ma'moon's presentation, my colleague, Mr. Ahmad Shahata, Beckman Coulters Product Manager for Chemistry and Immunoassay, will talk about Beckman Coulters AMH assay design and its related performance characteristics. Throughout the webinar, please make sure to add your questions to the Q&A box and fill in a short evaluation poll at the end of the session. Also, please explore the link attached on the webinar console. The floor is yours, Dr. Amr, and thank you for being our speaker.
Thank you, Grace, for the wonderful introduction. First of all, I would like to thank Beckman Coulters for extending their kind invitation. Second, for those observing the holy month of Ramadan, Ramadan Kareem. And if you're fasting, lay back and enjoy. Today, our talk will be about the modalities to preserve female fertility, which is a hot topic actually these days. And a lot of people are, because of the social changes that the world is experiencing, a lot of women are thinking about ways to take, to be more empowered and make more wise and intelligent reproductive decisions. But before we go into this, for those who don't know me, I'm Amr Ma'moon, as Grace kindly introduced me. I'm a consultant of clinical genetics and the head of the clinical genetics lab at Cairo University Children's Hospital. I'm also a managing director of a leading genetics, private genetics center in Cairo, Egypt. And in my practice, the greater majority of cases are for issues related to their, for women coming in for their reproductive health and having issues regarding their reproductive health, like failure to conceive, primary amenorrhea, subfertile women with irregular cycles. And these women are referred to me to understand if it's a genetic or not condition, if the cause is genetic or not, and for counseling, for them to make more informed decisions about their reproductive health. Unfortunately, most of these women start seeking medical advice late, either at advanced ages or after they get married and they fail to conceive for several years, which sometimes is too late. Of course, I have nothing to declare, except that we use Beckman Coulters instrumentation, and we're very happy with their analytics, and that's why I'm very keen to speak with Beckman Coulters, because we tried all other platforms and we're very happy with what we're getting from the kits and analyzers from Beckman Coulters. I think everybody knows who this lovely lady is. She's Jennifer Aniston, the Hollywood superstar. And she recently, a couple of years ago, did an interview and mentioned that I would have given anything if someone had said to me, freeze your eggs, do yourself a favor. You just don't think about it when you're that age, of course, yeah. So here I am today, the ship has sailed. She tried everything, but she tried after the age of 40. So it was too late, and her ovarian reserve was completely depleted, and she wasn't able to have kids. This is the slide is about the changes that happened in the world. The world social norms as regards to the age of marriage changed dramatically. If we observe it from 1960 to 2018, when the National Center for Family and Marriage Research did this study, in 1960, 16% of women who married for the first time were younger than the age of 18. But it was reversed, actually. In 30 years after that, in 1990, it was 4%. And in 2018, it became 2%. Whereas, if we look at the number of women who were 30 years and above when they first got married, in 1960, it was just 6%. And it started rising to 16% in 1990 and 40% in 2018. So we can see this marked shift in the demographics and social norms. And I believe that if we keep on going, maybe in 2024, if they did the study again, it would have risen to 50%. Actually, from the recent studies, and this is from the premature ovarian failure update. From the very renowned Fertility and Sterility. Actually, it was done in 1998, but actually it's still the same. In women with primary amenorrhea, the prevalence of primary ovarian failure is between 10 to 28%. That's a huge number. A huge number of women that could have actually been saved if they tested earlier. In those with secondary amenorrhea, premature ovarian failure constitutes anywhere between 4 and 18%. So it's not uncommon. Considering these incidences, the rates and potential for women who fail to perceive the end of the month bleeding is a huge medical problem. And some people actually place it as 1% of the entire female global population. The next is going to be a video that will have a real life story so that people can personalize with it.
In all that sadness or whatever, then what do you begin to think because of what happened to her?
So Catherine then makes the phone call to me. I was in London, and she said, I've had some really bad diagnosis. It is the early menopause, and there's a high chance that it's going to be hereditary. Therefore, if it's happening to me, it's going to be happening to you.
In all that sadness or whatever, then what do you begin to think because of what happened to her?
So Catherine then makes the phone call to me. I was in London, and she said, I've had some really bad diagnosis. It is the early menopause, and there's a high chance that it's going to be hereditary. Therefore, if it's happening to me, it's going to be happening to you. You need to go and have all your levels tested. And at this point, I'd met, you know, my wonderful partner, who's amazing, and I knew that I wanted to have a family with him instantly anyway. So I hooked up with the women's clinic. They've been amazing, the London Women's Clinic. We went down there, had all my tests done. I've got a very low AMH level, which is Anti-Mullerian Hormone, which is one of the markers for low ovarian reserve. So basically, I don't have many eggs left.
So that rules out getting them stored.
So then I said, what do I do? You know, you need to help me out here. I'm not, you know, it felt like a ticking time bomb for me. So I tried to egg freeze. I only had 5 follicles, and I had to spend 12 days injecting my stomach. Only one I could harvest, and they didn't harvest it in the end because they normally like to take 15 to 20. So I sort of left with, you know...
Then you start to really panic then, because you think, I can't even freeze them. I've got to literally use the eggs I've got, and quickly.
Yeah.
What about your partner? Because you were saying you knew he was the one and things, but did this, like, not force his hand, but you then have to have that conversation saying, you know, I know we talked about children one day, but we are going to have to really get on with it now.
Yeah, I mean, I really need to take my hat off to him because he handled the whole situation amazingly and kept me really calm and was a very, you know, some guys probably would have freaked out about it. He just kept totally, you know, level-headed, and he was like, we'll deal with this together, and you know, we decided that we would try to have kids naturally.
And how quickly did you get pregnant?
4 months.
4 months. And you obviously knew that this was all happening, and we've already said, you know, how did you feel when your sister told you that? Very difficult. If you're really honest, did you have a moment where you were very upset about it?
Yeah, I mean, it has been extremely difficult. So not only Zoe, but my wonderful sister-in-law's also pregnant as well.
Oh, God.
So it's a case of... Yeah, I was fine at the time and held it together. We had a cry in the restaurant, but on the way home, I had to pull the car over on the motorway and just bawled my eyes out. I just... It was devastating.
Of course. Catherine, this is the subject of the phone-in today that we're going to have later on, and you hear what we're talking about. Number there on the screen, maybe you've just discovered a history of problems conceiving in your family. You're listening to Zoe and Catherine's story as well. But what advice would you offer to someone who maybe has this history in the family? You know, why should you think this would happen to you? You know, there's no real reason to think. But what about you? Have you ruled out having children in your life now because of this?
No, I think it's something that Tom and I are actively looking at. I've actually been for initial tests at the women's clinic, and we're definitely looking at egg donation. So there are some amazing women out there who will donate their eggs. So now it's a case of looking at fresh eggs, frozen eggs, and I never thought I'd sort of be shopping for frozen or fresh eggs, but it's
well,
really
how amazing
exciting.
that you have that option. I mean, I know how very hard for you to you know, to find out you can't do that naturally yourself, but at least there is that option. And if you didn't do the IVF and egg donor route, would you ever consider adoption?
That's definitely something that we've looked at. We've been to an adoption open evening to get more information. I think just at this stage, knowledge is power. So we're looking at every single option available and yeah.
I think the reason that we are speaking so sort of outwardly about this is because we really want to raise awareness. It is all about, you know, you're taught as a teenager to obviously use protection, don't get pregnant, all the rest of it, which is absolutely should be part of it. But the other side of it is explore your family history, get your test done, because had I found out, and maybe I speak for you, at 21, I would have frozen eggs and had them in the bank. Absolutely.
And you can be tested, can't you?
You can.
Yes.
Yeah, so you can have your AMH tested, and I probably would have had it done every 2 years in my 20s and then every year sort of in my 30s just to check my egg reserves.
Look, really appreciate you two, because that's an amazing conversation to have, and I know it's very brave of you to do it. But as you say, we raise that awareness and...
Okay, so this was a real-life story so that people can personalize with what really is the burden on women who have this issue, and how they're through early testing of AMH testing, definitely we can solve a lot of these issues instead of going into late cases that have no places to go and nothing to do except just the final reserve will be to go to egg donation. But if they detected it earlier, as the lady kindly mentioned with the AMH testing, then she went directly towards egg freezing. And this is something that we're going to talk about it in details later. So basically, the primary ovarian insufficiency or premature ovarian failure, both of them are synonymous. So whether it's primary ovarian insufficiency or premature ovarian failure, both are the same thing, is often diagnosed by the fertility specialist when investigations of the infertile women showed either the elevated FSH or low estradiol E2 or low anti-Mullerian hormone AMH. And many cases of primary ovarian failure present with unexplained infertility. And this is the whole problem, that postponed detection and they diagnose it too late. And this is something that we're trying to reverse and to raise awareness for people to start testing earlier so that they don't have to resort to the same limited. I don't want to say that there's no treatment, but there's a limited option. So when they get their tests earlier and they get to know the results earlier, they're definitely going to have more options on their hands. So let's talk a little bit about the AMH physiology and the importance. As you all know, definitely, anti-Mullerian hormone is a peptide hormone that is produced predominantly by the granulosa cells in the ovaries. Studies have demonstrated that with the decreased number of the antral follicles, with age, AMH also, the serum levels also decline, and it will become invariably undetectable near menopause. Also, anti-Mullerian hormone, which a lot of physicians don't know or disregard or think it's something very insignificant, is also sensitized by the Sertoli cells in the testis and is one of the first hormones produced by the developing testis. And this is very important, and we're going to talk about this later when it comes to the area of disorders of, and this is something that all pediatricians and neonatologists in the NICU, in the neonatal intensive care unit, should be very aware of it. The AMH, of course, causes regression of the Mullerian ducts within the male embryo, which would otherwise develop as oviducts, uterus, and the upper vagina. When we're coming to talk about the premature menopause or premature ovarian failure or primary ovarian insufficiency, it's diagnosed, it's defined actually as the complete loss of the ovarian function before the age of 40. During the primary ovarian failure, progressive decrease in the number of and the quality of the oocytes in the primordial follicles happen. And primary ovarian insufficiency is the phase when there is some loss of the ovarian function, but may be considered as the initial phase of a lot of gynecologists like to define it as a step before the premature ovarian failure. So primary ovarian insufficiency is considered a step before, just a step before the full-blown premature ovarian failure. Some people during the primary ovarian insufficiency, they can experience regular menses and they may be able to conceive, but with difficulty. But the ovarian function and fertility is definitely reduced. The primary ovarian insufficiency is often diagnosed by the fertility specialist, and the presenting women is usually complaining of subfertility or infertility. So these cases present usually late. People who detect these cases actually are already seeking infertility treatment at IVF centers, and they are usually, from our experience, above the age of 35. So let's look at the causes of premature ovarian failure / primary ovarian insufficiency. Well, the exact cause of primary ovarian insufficiency I'm so sorry. Can you hear me now? Okay. Sorry for it was an internet disruption. The majority of cases are actually nobody knows the exact causes, but 10 to 20% of women with primary ovarian insufficiency have a positive family history. Either their mothers, their sisters, their aunts have had primary ovarian insufficiency. And some studies actually suggest there's genetic mutations, and actually there are genetic mutations that are responsible for percent of the cases. So, and 28% actually percent of the cases of primary ovarian insufficiency, like cases have Fragile X syndrome, and that's why a lot of people in the IVF centers test for what we call the CGG triplet repeat, which is the mutation responsible for Fragile X syndrome on the FMR1 gene, or if the lady is a mosaic variant of a Turner syndrome. And this will be a very apparent in their karyotyping. She can be very easily diagnosed for a mosaic case of XO syndrome. Some cases of autoimmune diseases were suggested as a cause of primary ovarian insufficiency, such as autoimmune thyroiditis and Addison syndrome, Addison disease. Metabolic disorders were also implicated, and more than 80% of women with ovarian insufficiency. Toxins, viral infections, cigarette smoking, chemicals, and pesticides can speed the ovarian follicle depletion, immune destruction of the ovarian follicles. So again, the diagnosis of primary ovarian insufficiency are mainly three items. Missed or irregular periods for 4 months, after definitely exclusion that there is an unexpected pregnancy. So missed or irregular periods for 4 months, E2, and a very low AMH. AMH also is not just for a depleted ovarian reserve. Polycystic ovarian syndrome is very well-known disease that's has a very high prevalence in men starting from the age up to the age of 40. And this will show, when they test, they will show a very high AMH level. So a high AMH level is ringing bell or an alarm sign for premature, polycystic ovarian syndrome. As we mentioned in the slides before, when we mentioned about the physiology about of the AMH being produced from the Sertoli cells in the testis, in patients with disorders of sex development, the serum AMH determination helps as a first-line test to determine the etiology. A low AMH is indicative of this genetic disorders of the sex development. A normal AMH suggests androgen sense or action. So this is extremely important that all our NICU specialists, especially neonatologists and people who actually attend deliveries, once they detect a baby born with an ambiguous genitalia, they have to do AMH testing immediately. Also, germinal cell tumors of the ovarian, of the ovaries, actually have a high AMH test, which could raise awareness also of cancers in the reproductive system of women. So this is actually a recap what we can benefit from the use of AMH. If we're looking at from the diagnostic side, then polycystic ovarian syndrome, which is a reason for definitely one of the main reasons of infertility. We can also predict the time left for the offspring to have kids. So that if it's in menopause, if she's having, and some papers and some in the literature are mentioning that sequential testing every quarter for AMH testing, starting from the age of once the woman gets married and is not able to conceive, then she should do her AMH testing sequentially every quarter. And this was actually published in the American Journal of Obstetrics and Gynecology. So it can be used as a prediction for the time of menopause. And as we just mentioned, as cancer, in cases of cancer, faster diagnosis for germinal cell carcinoma. And definitely once we can expedite the diagnosis, then we can expedite the treatment as well. On the left side, the IVF treatment. Once we know our ovarian reserve, we can give the woman who is testing more informed an informed idea about her fertility and her reproductive health, making her she can, based on this, make more informed decisions regarding her reproductive health. And maybe she would decide that if she's not married, that she can go for egg freezing. If she hasn't found the right partner, she can go for egg freezing. If she's married and trying to have kids, then she should expedite the process and not wait any further and expedite the process of IVF. During the infertility treatment process, during the IVF treatment, individualization is very important. A woman with a subnormal AMH level will not need the same treatment as a woman with an extremely low AMH test. That means that the woman with an extremely low AMH test will need more powerful ovarian stimulants and hormones, but a woman with a subnormal AMH level will need just a moderate or mild ovarian stimulation. So this will give the IVF specialist and the IVF doctor a much more informed decision about which drugs to use during the stimulation process, which is a very important step in the IVF process. And definitely it will give us an indication about the prognosis, about the success rate. A woman with a low ovarian reserve, which is indicated by a low AMH test, will be definitely expecting to harvest a minimal amount of eggs. However, a subnormal or a moderately low AMH test will give us a higher expectations for eggs. And this is important because based on these prognoses, the doctor will be able to tell his patient from the start that we will go through 2 or 3 cycles to harvest enough eggs, because they usually like to harvest anywhere between 15 to 20 eggs in order to give the woman a good chance of having a live birth. Prediction of primary ovarian insufficiency, and this is what it's all about. Early prediction. A decreased ovarian reserve describes women of reproductive age whose response to ovarian stimulation is reduced compared to other women of the same age. And this is, it's possible to assess this through, as we mentioned, FSH, E2, the antral follicle count, and most importantly, the AMH. High day 3 FSH and low E2 suggest decreased ovarian reserve. And the beauty of the AMH is that it's not dependent upon which day of the cycle that you test. Unlike FSH and E2, which are dependent upon which day of the cycle that you're testing. Antral follicle count, which is done by the ultrasound, is operator dependent. So you can have an ultrasound operator who can see 5 or 6, and then you can find somebody else who can say, no, it's not 5 or 6, it's 3 or 4. So it's operator dependent. But AMH is gonadotropin independent, and its assay can be done at any time of the menstrual cycle. And of course, AMH levels below 1 nanogram per milliliter are associated with decreased ovarian reserve. And as I just mentioned in the previous slide about the prediction part, Freeman et al. Suggested that the rate of decline in the AMH rather than the absolute AMH level is useful in predicting the age of menopause. And this is where I was mentioning that people who start going in for infertility treatment, before they do the IVF, they should go on a quarterly basis to test their AMH levels, because from quarter to quarter the level may drop significantly. And Nicolas et al. Reported that women who had a poor response to ovarian stimulation were likely to develop menopausal symptoms within 7 years. Now, we detected a woman who has an ovarian, premature ovarian insufficiency, premature ovarian failure, primary ovarian insufficiency. What can we do to help this woman? Oocyte cryopreservation, which is called egg freezing, known very familiar by the name of egg freezing, started more than 25 years ago. And the success rate of oocyte cryopreservation improved recently with the introduction of vitrification. Vitrification is a new way for freezing. Previously, before vitrification, they used to use slow cryopreservation. And this ended up in when the oocytes were thawed. A lot of the oocytes were not harvested and thawed properly and were degraded. But with the quick vitrification method, it's the fast cooling using, of course, special kits, and then the oocytes are placed in liquid nitrogen. This improved the pregnancy rate, and with vitrification now, the fresh oocyte, the pregnancy rate with fresh oocyte is no better than the frozen donor oocytes. So it's 50% pregnancy rate in both groups. And recently, there has been a lot of work done in the area of ovarian tissue cryopreservation, which is basically that it's a biopsy from the ovary. It's being surgically removed, and this, of course, this part of the ovary contains oocytes, and it's cryopreserved like the oocyte cryopreservation, but it has a lot of benefits. The benefits is that, of course, they can use it for women going in for ovarian cancer and undergoing cancer treatment. However, elective fertility cryopreservation, for non-medical reasons, it can help women for social reasons, especially as regard of the hot flushes and premenopausal symptoms. These can help relieve women in when they transplant the ovarian tissue. It will produce the hormones that started going down. And of course, we can use it. It will definitely give a larger number of oocytes than if we just do the oocyte cryopreservation through the regular techniques. So the take-home message is basically AMH is an important biomarker for prediction of women at risk for premature ovarian failure. And women with delayed menarche, primary amenorrhea, irregular cycles, excess body hair, and weight gain should test for AMH. Quarterly AMH level assessment can convey additional prognostic benefits for the infertile patient seeking fertility treatment. And the oocyte and ovarian tissue cryopreservation may expand the reproductive lifespan for women who wish to delay childbearing, especially these days. A lot of women are career focused and delaying either marriage or delaying either the childbearing age till after the age of 35. So this will help them big time. And we have to remember this slide again and this lovely lady again and what she went through. This is a live case that could have been prevented if she had done AMH testing at an earlier age and did her egg freezing. Thank you very much.
Thank you all. Now, my colleague Ahmed Shahata will explain about our AMH test design, and then we will take the Q&A with Dr. Amr. Go ahead, Ahmed.
Thank you very much, Dr. Amr, for the valuable information, and thank you, Grace, for the introduction. I'm going through the assay itself, how we can take all of this when we have the proper tool in order to assess the ovarian reserve. We will go through the testing advantages of the Access AMH assay. So as Dr. Amr highlighted, the infertility is prevalent worldwide, and the numbers we see here from the WHO from 2010 reflects how we have a lot of people live with infertility and they need help in order to plan for a child. So we have approximately 186 million individuals who has infertility globally, and those need a lot of help in order to get a child. So the AMH is reflecting the number of follicles that has a potential to ovulate, and it has or provide the indirect measurement of the ovarian reserve in terms of the quality and quantity for the woman planning to get pregnant. One of the advantages for the AMH that it has a constant level across the menstrual cycle. So we will be able to monitor it at any time during the cycle, at any time during the phases without the need to wait for a certain phase in order to get a result, unlike the other markers that was used before. When we look to the advantages of the AMH versus the FSH, we will see that it provides a constant level over the whole menstrual cycle, less variation between the cycles, and it provides more sensitive and specific information about the decreased ovarian reserve. It also gives additional information about the age-specific cutoff. The intended use of the AMH in a simple way, it's a paramagnetic particles chemiluminescent immunoassay available on the DXI and Access 2 analyzer. It helps in the quantitative determination of the anti-Mullerian hormone levels in the serum and plasma using the different platform. We have one part number that can be used across the different immunoassay platform that we have in Beckman Coulters. And here are the part numbers for reagent, calibrators, and controls. You might have noticed here that we have 3 levels of the control that covers the whole measuring range of the assay. When we look to the journey of the development of the AMH, Beckman Coulters had the chance to launch the first available AMH ELISA system in 1999. And with the continuous development, we launched the automated one in 2014. And in March 2021, we launched AMH Advance, which has a specific cutoff based on the different medications. When we look here, we are not only offering the AMH, but we also offer our comprehensive reproductive assay menu, including the prenatal screening and also the reproductive endocrinology test, including the LH, progesterone, prolactin, in order to assess the clinician to get the better picture about the reproductive health of the woman. Moving to the assay characteristics, how fast you can get a result. So for the AMH, The format of the assay is one-step sandwich assay. The pack size comes with 50 tests, and we have 2 packs in each reagent box, which means when you order 1 box, you can get 100 tests. The time to the first result is 40 minutes. The sample volume is 20 microliters only. And both serum and plasma, lithium and heparin, could be used. The onboard stability for each reagent pack is 31 days, which could be utilized easily for 50 tests within this time. So if you have low number of tests, you will not waste the reagent. You can use it within 31 days. Once you open the calibrator, it will be stable for 90 days at the normal fridge between 2 to 10. And we need to calibrate the reagent pack every 31 days, which is also quite enough time to have stability for calibration curve. And the calibrator comes with 6 different levels, and we have 3 levels of the control. When we look here to the values, these values covering the whole measuring range. And the control stability is coming 2 days in the normal fridge and 60 days frozen, and we are allowed to refreeze it only 3 times. When we look to the assay performance characteristics here, we will see that our internal claims is showing less than or equal to 0.01 nanogram per ml for the limit of blank and 0.02 for the limit of detection, with an excellent CV, especially at the low levels. That reflects the prediction of the AMH level, especially in a very low concentration. When we look to the calibrator design, we have a state-of-art design for the calibrators. When we use synthetic matrix that stimulate the analyte-free human serum, because using of the serum-based calibrator might cause some interference because of the endogenous AMH, and that could reflect on the results, especially in the low levels, which is needed for the majority of the women who's testing the AMH. That's why the calibrator from Beckman Coulters provide an excellent lot-to-lot reproducibility. The synthetic matrix allows for greater stability. We also use recombinant human antigen, where the calibrator more accurately simulates the behavior of the AMH in patient sample, which provide a greater immunological recognition of the AMH antibody and deliver robust assay design. When we say state-of-art, we mean it. We use the recombinant human antigen versus the traditional bovine antigen. And here, that give us a stability of both calibrators, controls, and consistency in the patient result, especially when we have many reagents calibrator, if we have a lot of assays or a lot of patient sample. And since the calibrator should simulate the behavior of the analyte in a real sample, the greater the immunological difference between the AMH and the sample and the calibrator, the less robust the assay will be against day-to-day variables, such as the temperature, speed, and different reagent patches and others. That's why use of the recombinant human antigen provide robust performance of the assay. When it comes to the calibrator and control, it's important to have a long stability for both of them. The calibrators comes lyophilized with the 6 different levels. When we reconstitute it, it will be stable for 90 days between 2 to 10. And the concentration will be between 0 to 24 nanogram per ml. And this calibration curve will be valid for 31 days. When you talk about the QC, it also comes with the lyophilized materials, 3 different levels, 2 vials for each levels, and the reconstituted controls will be stable for 2 days when stored in the normal fridge. And it can be used up to 60 days if it's frozen, and we can refreeze it up to 3 times. What we see here with 3 different concentrations for the QC, in order to cover the maximum of the calibration curve, to have a visibility on the performance of the assay across the whole measuring range, if we have a low patient result or high patient result, in order to have a continuous monitor for the patient data and also for the performance of the test. The sample types and handling. We can use both serum and plasma, lithium heparin. The sample will be stable in the room temperature up to 24 hours, but if we will not test it during the first 24 hours, we can keep it in the fridge between 2 to 8 up to 6 days. If we run it as a batch and we will run it after 6 days, we can keep it at -20. It will stay longer. And we are allowed to thaw the samples only twice. After that, the sample will not be stable. So finally, the Access AMH takeaway message. Using the Access AMH assay will deliver the patient result in less than 40 minutes in an automated system with a very high capacity like the DXI 800 or the DXI 9000, where you can generate 400 or 450 tests per hour. Establish robust analytical performance, is not subject to biotin or any other complement interference, so we will not suffer of the interference factor that might affect the patient result. Also demonstrate short and long-term sample stability through the vigorous investigations. It provides an excellent correlation with the low AFC than the manual or the traditional assays used. And finally, adding one of the pieces to the integration in the lab, it reduces the laboratory cost by 16% over the typical manual test. And of course, minimizing the operation efforts in the lab. So by this slide, I just made a very simple message about the use of Beckman Coulters Access AMH. And we are here to answer your questions. Thank you, Grace, and the floor is yours.
Dr. Amr, we have so many interesting questions. Hope the time will allow us. I start with 2 questions from the same person, Mr. or Mrs. Akhtar. The first question is, what is the cause of irregular menses in the age of 14 to 15 years?
Thank you very much for this question. It's a very important question, and we face actually this dilemma on a regular basis, whether in the clinical setting or hospital setting. And actually, there are various causes that may cause irregular menses, or sometimes a delayed menarche. Irregular menses, it could be either delayed menarche, it could be primary amenorrhea. Sometimes it's just an endocrinal problem, and it can just endocrine sort out on itself. But we have to rule out the other causes, which are very important, like Turner syndrome, especially if she's a short girl or adolescent and her height is below average. Definitely a cytogenetic analysis should be ordered. Cytogenetic means doing a regular karyotyping, because sometimes even if she doesn't show the webbing of the neck, the carrying angles in the arms, subnormal mentality, she could be just a normal girl, just like any other girl, but a little bit shorter. And this will be sometimes turn out to be mosaic Turner syndrome. And definitely with mosaic Turner syndrome, we all know that the ovaries are a little bit damaged, a little bit atrophic, and there's an infantile uterus. So definitely this will affect the menses. Other causes do not apply to the 14-15 age except if she has galactosemia. Galactosemia is also a cause, but galactosemia should have been diagnosed since birth with the regular neonatal screening. Galactosemia is one of the known causes of, and 80% of cases with primary ovarian insufficiency are because of galactosemia. I hope this answers the question.
We have another question from the same person saying, what is the cause of irregular menses for 3-5 days, then 1-2 days, where like I went to the doctor, but then she said everything is normal. What might be the cause?
Well, if it's just a disturbance in the hormonal levels, then these can be, if everything is normal and and the lady tested her hormones and fertility hormones and everything is within normal range, then definitely this could be just a cause of just fluctuations in the hormonal levels. But as long as her AMH is normal, if she tests the AMH and the AMH is normal and not declined or not, of course, high level, because if it's high level, then it could give us an idea about polycystic ovarian syndrome. And polycystic ovarian syndrome causes disturbances in the menses and the regularity of the periods. So this is something that definitely needs to be ruled out. Not only the hormonal tests, but she should do a proper ultrasound so that we can see if there's any anatomical issues. If we're talking about the same age group, 14 to 15, or if it's older, then the same thing can be implied as well.
The third question, do we have similar reference ranges of AMH on different immunoassay analyzers, or should we consider different ones?
I think this is a question for Ahmed.
Ahmed, can you answer this question? It's okay. I'll move to a second question and answer. Ahmed, there's a question for you. Do we have similar reference ranges for AMH on different immunoassay analyzers?
So normally there will be a slight change in difference range between the different analyzers because of using different methods and using of different calibration curve. But at the end, all of them have a very good correlation when it comes to the final result. So there are a lot of publication on the different reference ranges and the studies of setting the reference range. So we will be sharing with the with all of the audience after the webinar is finished.
Okay. Dr. Amr, a question for you. What is a suitable age to preserve the eggs?
Actually, there is no suitable age, but the best thing to do is to get tested earlier, so that if the lady knows that she has a low ovarian reserve, then she should act immediately. She should act immediately, either if she's not married or is not in a relationship, then she should consider doing it earlier. But the early that she does the egg freezing and the cryopreservation is better, because actually the egg is actually frozen at its biological age. So for example, if a lady does egg cryopreservation or oocyte cryopreservation at the age of 25 or 26, then she freezes it, and then she gets married at the age of 36, 10 years after, she will be using an egg with the age of a 26-year-old woman. So that it's much better if she waits till the age of 36 and then does her cryopreservation, then the age will be preserved at the age of 36 with all it comes with all the genetic issues and the quality of the eggs would have deteriorated. So the earlier, the better. We usually recommend before the age of 30, because after the age of 30, the quality and the number of the eggs become a little bit lower. And especially if she tested for the AMH and her AMH is low, then she will be classified as a poor responder. And maybe if she tries to do her stimulation after the age of 30, then we will not be able to harvest enough eggs for her to have a successful childbirth.
Okay. I will skip all the questions related to the AMH intervals, but please, there is a link on your console that will allow you to access all the studies on AMH, all the latest studies. There is a new question, Dr. Amr. Can AMH test be used to diagnose PCOS?
Yes, of course, and this is what I mentioned actually in the presentation. Women with polycystic ovarian syndrome have high AMH levels, and this could be used as a screening test, especially with women having irregular menses before they do even the ultrasound. So a high AMH is one of the criteria of polycystic ovarian syndrome and can give an indication even before the woman does a detailed ultrasound, giving a very good idea if this woman is suspected to have polycystic ovarian syndrome, and get treatment at a very early stage. So yes, it's a test that can detect and can diagnose polycystic ovarian syndrome in combination with ultrasound.
Okay, perfect. Thank you, Dr. Amr. Another question for calibrators: what will happen if we freeze the calibrators?
So the question is related to the assay performance here. So let me take it. So the calibrator here is reconstituted, so it should be used once it's recalibrated, and it will be stable for 90 days. So we will not need to freeze it, because considering the calibration interval, we need to calibrate every 31 days. So you will not need to keep it in the freezer, because it will be enough for 3 different calibrators if you keep it in the room in the fridge 228, and each one is coming with 2 ml, so it will be enough for 3 different calibrators without the need to freeze
it. One more question that is close to every woman's heart. What advice, Dr. Amr, can you give to a woman who is still willing to give birth to a baby at the age of 40?
That's a good question, and it's really possible, and even women above the age of 40 can give birth to a normal child, either can conceive naturally, and this is something we've seen before a lot. And I'll give you a story that actually we've seen it here in Egypt a couple of years ago. Is that an Italian woman who actually tried doing IVF twice in Italy. She's 46 years old, 46, and she actually did 2 trials of IVF in Italy and failed. And she came to Egypt actually and got pregnant from the first trial. Thanks God, definitely. And to the wonderful team that were behind her clinical treatment. And she was at the age of 46, but this is not the rule. Actually, this is the exception. What I can advise a woman at the age of 40 is to test her AMH and check her AMH levels. If it's not too low, then definitely she should start
Dr. Amr, we are losing you.
Immediately.
I want to take...
To do egg freezing.
Dr. Amr, we lost you. We are still having one question. I will ask Dr. Amr to answer it, and we can message it to the one who asked it. So I want to thank you all for attending this webinar.
Thinking about having a child immediately, and then she can use these frozen eggs to have conceived at a later age. And we've recently used frozen eggs
we're sorry for the technical mishaps that's happened at the end. I want to thank you all for attending this webinar. Hope it was up to your expectation, and we want to welcome you in advance to all our future educational webinars as well. I want to thank Dr. Amr. I want to thank Mr. Shahata for their valuable input. Thanks a lot, and looking forward to our next activities. And please put your comment in the comment box. Thank you all, and see you in the next webinar. Bye.